we would have the next speaker, Dr. Bancha from Thailand. So he will talk with us in Thailand by webinar. It's a new fashion that we do during the pandemic area. So over to you, Dr. Bancha.
我叫周天才 I'm Dr.BanchaChernchujit from Thammasat University Hospital, Thailand. So thank you the committee and also the Smith & Fields for these invitations. I'm talking about the meniscus centralizations, my experience. Okay, so first let's look at the anatomy of the meniscus. So this is a very important structures for me. I think the meniscus is more important than the ligament. So you can do ligament reconstruction, revision 2 times, 3 times, but meniscus you can do only one. Okay, so let's save the meniscus. So this is a very vital structures. If you cut the meniscus, we cut it a lot in the past, and we cannot replace it with any tissue. Even the meniscus transplantation is not the same like meniscus that you repair. Okay, so try to save the meniscus. So this is the medial meniscus and this is lateral. So today we are talking about the meniscus extrusion or meniscus centralization. Okay, so it's always start with the meniscus tear at the root. This is the root of the medial side and this is the root of the lateral side. Okay, so most of the time medial side tear more common than lateral side. Medial side is very common in the middle age patient like 50 years, minor trauma, okay, like squatting or miss the step. But the lateral side is in the young. We find it in the young patient with ACL injury, right? So the medial side, lateral side is totally different group of patients. This is a classification, right? Everyone know about the meniscus tear. Today we are talking about the meniscus tear that produce a lot of problem. This is a radial tear. Okay, actually the meniscus root tear is a radial tear. It's the same thing but different location. Okay, so this radial tear at the body or radial tear at the root, this is the problem. So patient will come to see you with severe joint line pain. Okay, and if you didn't treat it, the patient will turn to be osteoarthritis very fast, because when you have the radial tear or root tear, it's like you have the torn meniscus, like you have total meniscectomy. Okay, because the meniscus loss of hoop tension, so it's extrusion and it's mean like you have no meniscus. So there's many ways of repair, right? So sometimes we need to combine with the all inside out tranosseous. Okay, so we need to know everything. This is a cause of meniscus root extrusion. Most common is the meniscus root tear, especially at the medial side. Okay, in the middle age patients from minor trauma like jogging, squatting, mid the step, twisting. Sometimes they cannot remember the occurrence, the accident, because it's very minor trauma. But after that, the patient will have the joint line pain, right? And also the radial tear, like I told you, a radial tear at the body. Okay, this will progress and the gap will be wider. Okay, and sometimes the complex tear. Okay, this is a cause of meniscus extrusion. Like this patient, you see that they have the radial tear of the meniscus, like that. Okay, so in the past we doing this way the meniscus repair. Okay, but the problem is the tension is always too much. You see that after we repair we still have the gap like that. So this patient we have bad results, because you can imagine that this meniscus cannot heal because the gap is too much. Okay, the gap is too wide and the vascularity to the radial tear is not good. Okay, it's not like the bucket handle longitudinal tear is totally different. So this kind of meniscus is very serious for me. Okay, so you just repair it. It's not enough because there will be too much tension. That's why nowadays we add the meniscus extrusion reduction. It's like the internal sprint to reduce the gap, right? I show you the patients, okay? So this patient has a discoid meniscus of the lateral side, okay? When you get in, you see that the patient have torn meniscus. This is the back, the discoid, okay? But discoid is not the problem. I think her problem is the radial tear. So after remove the discoid, you see that that is the radial tear, okay, at the body of the meniscus, okay? So after the socializations, then you see that the patient have a gap here at the body, close to the popliteus, okay? So first we do the trephination. But this patient is not so chronic. You see that they still have some granulation tissues, right? So we use the mini first pass, okay, repairing the radial tear, okay? Because at this area, it's difficult to use the fast fix because very close to the popliteus, right? So I make a big bite of the meniscus repair. First, we do the peripheral repair using the tape. This is the suture tape, you see? Okay, then cut it. And then we use the mini first pass again. Okay, and then we repair it like side to side. But the key step is you need to make a very big bite because this kind of tear, the radial tear, can easily cut through the tissue. Okay, so make a big bite. Okay, like that. Okay, then you can restore the radial repair. Okay, so this is a simple step. So in case the patient came to see you very fast, very early, you can do this way, and the chance of healing is pretty good, right? This is the way to do the meniscus radial tear. Okay, so now we're talking about the root, right? The medial root and lateral root, right? Okay, so the root tear, as I told you, the medial side posterior root tear is common in middle age, like 50, 40 years of age, and minor trauma. This is a radial tear that close to the root. By Laplace definition, is the root tear close to 9 millimeters. Okay, is it 9 millimeters? We can call this the meniscus root tear. It's a radial tear, right? Another thing is the lateral meniscus root tear. This is very common in the young, combined with the multiple ligament injury, combined with ACL injury. Okay, and this is, I think, there's a better prognosis because of we always find it in very acute stage, and we do that root repair together with the ACL reconstruction, right? So the lateral root sometimes is difficult to identify because that the Richburg ligament. Sometimes you misinterpret. You just see the meniscus floating, but you didn't know that this is meniscus root tear because sometimes there's no gap. You see that? That is a Richburg ligament. Yeah, you cannot see the gap because that's still extension of the Richburg, right? So the way to repair is the straightforward. You repair the meniscus to the tunnel, and also I repair the Richburg into the tunnel also, right? So this is like Y-shape attachment, okay? Richburg and meniscus root. Most of the time there will be little gap or no gap, right? It's just floating. So the good candidate for the meniscus repair is the acute. There's still some marrow edema, bone bruise. This is good indication. If the patient have no joint space narrowing and extrusion less than 3 millimeters, this is a good candidate to repair. And you should make a faster queue for the patients. If the queue is really long, right, you need to make it faster because if you let this happen, the gap will be wider, and also the cartilage will be gone, right? If you come too late, you cannot save this meniscus. So this is a bad candidate for the repair. It is chronic injury, joint space start to be narrow, and the gap is wider, and the extrusion is more than 3 millimeters. This is not a good candidate for repair. You see that this patient start to have some sclerosis at the medial side. There's a big cleft sign. There's a ghost sign. If you see ghost sign in many cuts, that means the gap is wide, okay, like this. This is not good for repair. Okay, and when you get in, most of the time you see some cartilage damage. Okay, so repair it before cartilage damage. Okay, keep in mind, this is quite important. This is the size of meniscus root tear, right? Everyone know that extrusion, got side and kept side. Okay, this is my articles. The simple way to do the meniscus repair, we call the medial meniscus root repair using the tibial tunnel suturing technique. It's very simple, right? I published this technique many years ago, right? It's good for the lateral side and good for the meniscus that have no extrusion. You make a transtibial, okay, and then you pass the needle. This is the meniscus needle, very simple, and retrieve the meniscus needle in the back, right? And you use the small cannula in the back, okay, and then you and easily pass the needle, yeah, into the tunnel. This is quite simple, and the meniscus needle is very small, okay, and we repair it in the Mason-Allen's way, right, like this. So this is very simple. It's good for the meniscus repair that's acute, no gap, right? You can do this way to reduce the meniscus. Okay, we call the trans-tibial tunnel suturing technique. Okay, and finally you get this Mason-Allen's repair. Okay, but this is for the simple meniscus. Another way is we call this the transtibial pull-out techniques. Okay, but you need to make a good raw surface, quite important, because the contact area between the meniscus and the bone is very minimal. Okay, and the transtibial suturing technique, sometimes you get the bungee effect, because over time the suture may be loose, and if there's some micro motion in the tunnel, okay, this meniscus will not heal, right? So this is the way we do the Mason-Allen's meniscus repair. Okay, one transverse, one vertical, and then to the tunnel, but make sure that the gap is not big, right? And that way. And very important, when you tension the suture, you should not make it too much tension, because this suture can cut through the meniscus. This is quite often, because I make a second look in operation in the past. We found that many of my patients have a cut through of the meniscus because we put it too much tension. Okay, so when you tension the suture, I recommend you to put the scope into the joint to see that the tension is too much or not, right? Okay, another way is to do the biplanar techniques. Okay, this is another techniques of mine. So we do the meniscus into the tibia, and also we make a side-to-side repair to the PCL. Okay, this is to the tunnel, and after that we make a side-to-side repair to the PCL, right? So you have two ways, one into the tunnel, and also you have the side-to-side repair to the PCL. So you can have the tissue healing in the tunnel and also to the PCL, right? So this technique also works very well, but the meniscus gap should not be too big. If you have too big, you cannot repair the meniscus to the PCL. Okay, so this is another technique I propose this. We call biplanar meniscus repair, combined with pull out and repair it to the PCL. Okay. In case you have the ACL together with the medial lateral root, this is my report. Okay, technique case report in arthroscopy. So this patient have torn medial side, torn lateral side, and also ACL reconstruction. So the way to do that, you need to make sure that the tunnel will not jam. Okay, so two meniscus root will be on the lateral side, and ACL will be on the medial side. So this is the way to do the meniscus repair. If you have the medial side tear, lateral side tear together with the ACL reconstruction, you see that on the lateral side, most of it's just floating like this. There's no gap, right? You see, there's no gap. There's a Ritzberg ligament is over there, okay? But you have no gap on the lateral side, okay? And then you pass the suture into the tunnel, and after that we make an ACL reconstruction, okay? So from the literature, we found that there's a valley from 60 to 90% of the meniscus complete healing. Okay, For myself, I think my result is about 70%, 60 to 70%. It's not 90%, because I think most of the patient came to see you too late. If the patient come early, the result would be better. And another problem is we cannot reduce the meniscus extrusion. Only 56% had the meniscus extrusion reduction. Okay, so this is a problem, and nowadays everyone recognize that the meniscus extrusion is important. It's important, not just the root repair, because root repair you cannot solve the meniscus extrusion problem. Okay, if the patient came to see you very late. And this is also another paper mentioned about the meniscus root repair. They found that the root healing is just 60%. Okay, same things. And this is a biomechanical consequence of the tear of the meniscus root of the medial side. Okay, the literature mentioned that this is a classic paper in Journal Bone and Joint. They found that if you have the root tear, it's similar to you have total meniscectomy. Okay, so that's important, and the meniscus extrusion is the key. If you can reduce this extrusion, you reduce the tension strength, reduce the shock absorption, and also reduce the progression to osteoarthritis. So only meniscus root repair is not enough. Okay, believe me. So when the meniscus root tear, this is a consequence. Okay, they start with meniscus root tear first, and after that, over time, there's a detach of the tibia from the plateau. The meniscotibial ligaments start to stretch, right, and alter the native joint kinetics. Meniscus extrusion happen, and after that, it's like you have no meniscus. You look at this picture. When you have extrusion, it's same like you have no meniscus, right? Okay, same like you have no meniscus. So the cartilage loss will be very rapid progression. Okay, rapid progression. This also happened to my mother. Okay, yeah, water mama, my mother. My mother have meniscus tear, meniscus root tear, also have radial tear. Okay, and I missed the diagnosis because X-ray look normal, and my mother cannot get into the MRI tunnel because she has a claustrophobia. She cannot get into the tunnel. And 5 years after that, my mother need to do the total knee arthroplasty. Okay, so I'm very sorry, I cannot save her meniscus. So the isolated meniscus extrusion associated with the meniscus tibial, meniscotibial ligament abnormalities, as I told you. Okay, if the extrusion is more than 3 millimeters, the meniscotibial disruption is 100%. Okay, so the extrusion, the degree of extrusion is quite important. Okay, so the prognostic factors for the arthroscopic pull-out repair for the posterior root tear of the meniscus, the prognostic factor is depending on the extrusion, right? If the extrusion happen and we not reduce that, the progression of the osteoarthritis will be progressed. Osteoarthritis will come very, very soon. So centralization of the extruded meniscus will improve the meniscus coverage on the tibia, right? That's protect the cartilage and delay the cartilage degeneration. So this is another article mentioned about the pull-out fixations of posterior meniscus root tear. They found that if you can reduce the meniscus extrusion, they have better knee score, like the Lichholm score, IKDC score, and KL arthritic progression. Okay. So, okay, another paper mentioned about the extrusion. Okay, more than 3. The definition is more than 3 millimeters. If we can save that, if we can reduce extrusion, the long term after the meniscus repair, the osteoarthritis will be limited and the meniscus function seem to be preserved. Okay. So you mentioned about the techniques. This is my way of the meniscus repair. I drop the leg down at the end of the table because we can go around the knee. We can go front and back. Okay. So first of all, you need to make the medial joint space opening. So this is my paper. just published last month in the arthroscopy. We call this the extrusion, the magic point. Where is the magic point? Okay, so magic point is a point that you can open the joint suddenly in one shot. You draw the line from the posterior cortex connecting to the adductor tubercle. Okay, it's about 1.2 centimeters from the joint line. From this line, we call this TU line. So from this line, if you touch the point, the joint will open suddenly, and you can hear the pop sound. Okay. So look again. This is one patient. I put the needle in. I just touch this magic point. You see, it sudden pop. You can hear the pop, and also your assistant can hear that. So if you open the joint wide enough, you have space to work. Okay, because I saw many patients that didn't release the joint space adequately, and they create a lot of cartilage damage in the surgery. Okay, so see again, put the needle number 18. Okay, touch the point, then the joint will open, pop suddenly. This is what we call magic point. You can read my article in arthroscopy technique journal. And very important, you need to make a good bed, right? Bone bed, and also trephinations to the PCL and this bone bed. Make a good QLED. But in case the patient have the cartilage damage like that, you need to back up the high tibial osteotomy procedure also, right? Because just meniscus repair is not enough. You cannot solve the knee pain problem, right? Like this patient have root tear. Okay, we repair the root, and also we do the high tibial osteotomy. You see, her cartilage quality is not so good, right? But the important that you need to save the suture. Okay, how to save this suture in the meniscus root repair, because when you do osteotomy, sometimes you can cut this suture. Okay, so I tell you the trick later. So another part articles mention the meniscus posterior root that restore the intraarticular volume of the medial meniscus by posterior meniscus extrusion reduction. Okay, and you see that when the patient bend more, the extrusion will be more when the patient bend, right? And that produce cartilage damage. So this transtibial root repair will limit the ability of the meniscus extrusion. Okay, so especially when the patient make a bending more than 90 degrees, the extrusion will be more. So thank you, Dr. Mikun, for his animations. It's very nice. Prof. Mikun Shesheni, you make this for me, right? This morning. So this is the way you look at this animation by Prof. Mikun, right? You see that if you have 2-point fixation, that will be better. Okay, because you just pull one limb is not enough, because this extrusion is still there. If you pull like this, right, do the 2-point of pulling, you can do the extrusion reduction better, right? So this is my way. If they have a really big gap in chronic case with the extrusion, I will try to do this way. I make the transosseous repair and also the extrusion reduction. Okay, so you can read this article we publish, yeah, like this. You see that this is the extrusion reduction. Okay, so this is our article about the extrusion reductions, yeah, using the transosseous technique. Okay, published in the European Journal of Orthopedic Surgery and Traumatology in 2018. This is another patients that have the torn meniscus and do the extrusion reductions. Okay, root tear and extrusion reductions to the tunnel, like that way. So the post-op, the extrusion getting better. Also, this article mentioned about the placement of anatomic tibial tunnel. This improves the medial meniscus posterior extrusion at 90 degrees after the meniscus root pull-out repair. So the key point is you need to put the tunnel very close to the native footprint, because if you put it too far, you cannot reduce this extrusion. That means you need to make a centralization, okay, antilization and centralization, okay, that will reduce the meniscus extrusion. Okay, this is another articles also mentioned about the root repair together with the extrusion reduction. This will restore the tibial femoral contact better. I propose another technique. We call this the all inside, because sometimes you need to do the osteotomy, you do transosseous, there will be too many tunnels. So this is another way to do the extrusion reduction. We make a medial portal, and then we put the suture anchor. Okay, look again in like this. So this is a medial portal. Okay, and I prefer to use the suture fix from the Smith Nephews. Okay, coming from the medial portal. Okay, and then we put the anchors into the tibia, and then we make the extrusion reduction by repair the peripheral part of the meniscus. After you make the extrusion reduction, the tension of the root repair will be reduced because you make like an internal sprint. So this extrusion reduction will help your meniscus healing. Okay, so this is using the, instead of using transosseous, I use the suture anchor. Okay, using the suture fix to reduce the extrusion reduction. Okay, so you can see that this is before the extrusion reduction, this is after. You see the meniscus coverage on the tibia is much better. Okay, and the x-ray post-op also look nice. Okay, so advantage of this technique comparing to the pull-out technique is that you have no bungee effect, because if you make a long suture, you may have the bungee cord effect, and also there's some micro motion inside the tunnel, and you have no risk of the suture abrasion because the fixation is close to the joint. Okay, and easier to manage. In case you need to do osteotomy, in case you need to make a tunnel, you have no problem because you're working on the surface. Okay, so the disadvantage is the risk of loosening of the suture anchor over time, right? Okay, so this is a technique. So this is another patient. They have the meniscus radial tear. You see there's a lot of extrusion. You see the whole tibia like that. So this is a complex tear of the meniscus. There's a radial tear and also the complete extrusion on the meniscus. So in this patient, if you just repair the meniscus, you cannot solve the extrusion problem. Okay, so first I identify the tear site. This is a chronic tear, and patients start to have some cartilage damage, right? You see, this is a radial tear. So first of all, I do the extrusion reduction. You see a lot of extrusion. It's like you have no meniscus. You make a transosseous, okay, and drill the tunnels at the edge. Okay, use an endo button rim, 4.5 millimeters, pass the suture in like that. We use a medial portal, okay, and then use a suture hook. Okay, I always use a 3 stitch. Okay, 1, 2, and 3. Okay, pass that and make a horizontal mattress like that. And I always change the suture to be the tape like that. Okay, put the loop in first and then change to the tape, and then use the second stitch. Okay, and then we make it like a horizontal mattress. So this is a way to do the extrusion reduction. And the last stage, the second stage, I put 2 sutures in 1 hole. Okay, so we have less trauma to the meniscus because we have only 3 holes, and we can reduce the meniscus back like that, and then pass the suture into the tunnel like that. Okay, like that. You see, after we put in, the extrusion was reduced, and also you see the gap. See the meniscus gap getting better. Okay, and then we also do the all inside meniscus repair if you can. Okay, then we do the side to side repair, one in peripheral. Okay, and then tie the knot. Okay, So this is the way to do the extrusion reduction. At the same time, you make the radial repair. Okay. So the key is you need to make a big bite because the repair is parallel to the meniscus fiber. So when important, need a big bite. Okay, otherwise it would get the cut through the tissue. Okay, like that, and one in the peripheral part. Okay, so you see that after the repair, the extrusion reduction and the repair, the meniscus coverage on the tibia is getting much better. Okay, and the patient quite happy and have a good healing. Okay, this patient lucky because the culture is still not so bad, so I don't need to do high tibial osteotomy because his meniscus, his cartilage quality is okay. Okay, you see that coverage is better, and also we reduce the extrusion. Okay, so this patient came to see me too late. You see that the patient have complete extrusion, cartilage loss. Okay, and I try to reduce this meniscus back. It's not easy. It's at the big gap. So this kind of patient is not good for repair. Okay, so this one I think you need to do combine high tibial osteotomy. Even the patient have no axis deviations. Okay, sometimes I use the one leg standing view because if you use the scanogram or two leg view, you didn't see the real pathology. Okay, you need to make a we call one leg standing view. Okay, you can try. You can see the joint space narrow if you let the patient stand. You see that the big gap like that. This is not good. Okay, because you cannot. The tissue quality is bad, and also, yeah, you cannot reduce it back. So I can imagine that this patient, the meniscus will not heal because the gap is too much. Okay, so sorry because the patient came too late. So that's a new idea we call this Jinggu Kim from Korea. He proposed the meniscus reconstruction. Okay, I think this is a good idea because sometimes the gap is too big. You cannot reduce the meniscus back. So we use a gaseous tendon to pass into the meniscus into the bone. This acts like the soft tissue link. So if you still have big gap, it's not the problem because you have soft tissue link between the meniscus to the bone, right? This is the meniscus root reconstruction. And I did this technique. I feel that the result is better than the repair. Okay. So if the patient come to see me very late, the big gap, so I prefer to do this meniscus root reconstruction. Okay. So this is the way we start with the same way. Okay. And you just have only one hole in the meniscus. We put the suture in the meniscus and then I dilate the meniscus with Ethibond suture. Okay, most of the time we put 4 sutures for the gaseous. Okay, you dilate like that. Okay, two times, and then we pass the meniscus into the bone like that. Okay, you look again, drill the hole, pass the gaseous into the meniscus, and then put into the bone, right? That way. So this is a meniscus root reconstruction. It's like the soft tissue link. It's good for the patient that have the gap, big gap or chronic tear. Okay. So this is the another meniscus root reconstruction. You see big gap. Okay. So you see that the patient start to have some cartilage damage after the magic point. Then we make a tibial tunnel, pass the meniscus. Okay. So this patient we need to do combine with high tibial osteotomy because the cartilage also damaged. Okay. And then we pass the meniscus into the tibia like that. Okay. So this is after the complete, and then you can fix it securely with the screw. Okay, like you do Acl Reconstruction, but this is a gasless graft. Okay, this is meniscus root extrusion. So this is post-op. You can see that meniscus floating like that, big gap, and after the repair, the meniscus is healed to the tibia nicely. Okay. So this is my friend. He's a famous orthopedic surgeon in Thailand. Now he's become the president of Thailand Orthopedic for Sport Medicine. Okay, he's my good friends, and he has knee injury after jogging. He said, "Oh, Dr. Bancha, I have so much pain at my knee. I cannot operate." So I sent him for MRI. You see that he has a radial tear, and he start to have the extrusion of the meniscus. Okay, this is radial tear, and also it has the extrusion of the meniscus. Okay, you see extrusion. Then I make a meniscus extrusion reductions for him, and then we make a side-to-side repair using the fast fix because the tissue quality is not so good. Okay, so finally we reduce the extrusion and repair the meniscus back. So he's happy now. He can go back to sport again. Okay, this is my good friends, the president of Thailand Orthopedic for Sport Medicine. So another patient, 68 years old, has 1 year of knee pain after squatting and hear the pop sound, right? So the patient have the meniscus root tear, and the patient start to have some arthritic change, you see? So this patient we need to combine. I use the suture anchor, okay? Because we do a high tibial osteotomy, it's easier to use a suture anchor because you have no tunnel, right? Then we reduce the meniscus like that, okay, and then combine with the high tibial osteotomy, okay, and after the reduction you can see that the gap will be smaller, and then you can repair the meniscus back to the PCL, okay, and we do the high tibial osteotomy also. See, patient quite happy. Another patient, 55 years old, also have the knee pain, and he has the meniscus root tear also. I do the root reconstruction. See the MRI, the meniscus healing into the tunnel nicely, okay. But anyway, after surgery, we need to be very careful. We protect the weight for 6 weeks, and around range of motion about 0 to 90, and quadricep exercise, okay. Very delay, very slow rehabilitation for this meniscus root tear. So the take-home message for the meniscus root tear that we are talking about centralization. First, we need to do it as soon as possible. If the patient come acute, so take the chance to repair the meniscus. Otherwise, it turns chronic. It will be difficult. Okay, when it gets chronic, you need to see that the patient have cartilage problem or not. If the patient start to have cartilage problem, like at 3, 4, you need high tibial osteotomy or UKA or TKA, right? But if the patient still have the like grade 1 or 2, you can do the meniscus repair. If the gap is small and the alignment is still good, you can do the meniscus repair. But in case the patient start to have malalignment, we need to combine with high tibial osteotomy, repair or recon, depending on the tissue quality. If the gap is too big, I prefer to do reconstruction. Okay? Thank you.